Hi, we still have folks coming in. We'll get started in just a minute when we look like we've got more folks on the call.
I'm talking to myself over here. Sorry, guys. I'm running a minute late today. We'll give everybody one more minute in case they were doing the same thing I was, and then we'll get rolling.
I covered for you, Chad. I made like we were just waiting for more people to come. I didn't say you were late. No one would have noticed.
I appreciate the thought.
You're
I can
welcome.
own it. Suddenly everybody has the, hey, can I talk to you for 1 second? Even though I was standing next to them all morning long. All right, so it's 12:17. So why don't we go ahead and get rolling? So welcome back, everyone. Hope everyone is doing well and getting ready for the holiday weekend, into the hottest days of summer. So several things I wanted to talk about today, most of it having to do with Delta variants, obviously vaccination discussion, and then looking towards the fall, because there's been quite a bit of development in recent weeks about if you kept up with Houston Methodist, they let go of 153 staff that refused vaccination, and that created a big storm. Now, just I think it was last week, Mass General has announced that they will mandate vaccination for all of their employers. And once a group as large as Mass General does it, you can expect that it will cause a ripple effect across other large institutions. So there's lots of changing pieces of the landscape. Vast majority of it is good, but it is going to create some interest and changes as we go forward. So starting out with kind of where we stand. So Western New York in general, and inclusive of the Finger Lakes, is at the lowest point of incidence since the pandemic began. So that is great. Most people would say that this is the same effect that we saw last summer that is accelerated by the propensity of vaccination. So the vaccine is working, which is great news. And the warmer weather, people kind of naturally spreading out and not being as cloistered indoors is probably making a difference. Having gotten through the school year may be contributing, although I think most of us would agree the schools seem to be probably the safest place that kids could be. It's what they did when they got out of school that seemed to cause problems, especially for the teenagers who are now becoming increasingly vaccinated. So that is all good news, although I will say perhaps not inclusive of Western New York. Many places in the country are seeing an acceleration of the Delta variant. So especially the states that are lagging behind in vaccination is where we're starting to see the Delta variant increasing. Now in predominantly international circles, we're also starting to see this Delta plus variant, which really has not reared its head in the United States to any significant capacity that I'm aware of. But the Delta plus variant is kind of, as best we can tell so far, the Delta variant on steroids. It is more transmissible. It does seem to be more associated with hospitalization and more severe outcomes. The Delta variant definitely seems to be more transmissible. However, it is not completely clear at this point that it is associated with more hospitalization or worse outcome. There's a little bit of conflicting data on that part. Nonetheless, for the states that have high levels of vaccination, of which New York is one, the currently available vaccines are all very active against the Delta variant. We obviously have not seen a lot of data about the Delta Plus variant at this moment. So most of those states who have seen significant vaccine efforts and success have not seen huge outbreaks of the Delta variant. And in the western part of New York and Finger Lakes in particular, it does seem that the Beta variant or the UK strain still seems to be the most predominant at this point, whereas the Wuhan strain is starting to fade a bit at this point. So what does that mean for us? Right now, I don't think it changes anything. I think for younger children, the concern is that will the Delta variant become the highly transmissible variant in young kids? And will that portend worse outcomes? We don't have the data to say it will portend worse outcomes at this moment. It very well could mean that young children, who may have less attentiveness to hand washing and other social distancing measures, that they may be more prone at camps and play dates and whatever the case may be to be vectors of this Delta variant. And because they are not candidates for vaccination, they could be transmission risks. It epidemiologically makes sense, but at this point, it doesn't seem, even in the states who have not had great vaccination programs, that it's the young children that are the big rise in cases. Now, as cases fall across the country, it is true that younger people are predominantly or higher percentage of the cases than they were, say, 6 to 12 months ago. But a lot of that has to do with just the success of vaccination in the elderly population and even adults at this point. So it's something we'll keep an eye on. And I certainly suspect that we'll be hearing more and more about the Delta variant, about whether the Delta Plus variant is showing up in the United States. But at this moment, it probably is more press excitement than it is true concern, at least in this Western New York region at this time. Next thing I want to talk about while we're on the topic of the Delta variant, at the last session that we had, several folks reached out because I had mentioned that there had been some concern raised about the success of the AstraZeneca vaccine against the Delta variant. And a couple folks actually reached out and said, hey, I've heard that the AstraZeneca vaccine is actually quite effective against the Delta variant. And lo and behold, that does appear to be true. So both Dr. Falsey and now there was an article that came out, can't remember where, Monday, that actually showed the AstraZeneca vaccine seems to be just as effective against the Delta variant as the Pfizer vaccine, or pretty close, and as we suspect that Moderna vaccine is as well. J&J, the data is still pending, so we don't know as much. There has been some concern that the efficacy against the Delta variant may not be as prolific. Certainly the South American variant is a concern there, and even potentially with the AstraZeneca vaccine as well. But I did want to clear that up because several folks raised the concern, and it does appear that the more recent evidence, and Dr. Falsey probably knows as well or more than anyone, that the Delta variant would be covered by AstraZeneca. However, it does remain true that that vaccine is not available except under study protocols in the US at this point. So that hopefully will be changed in the near future, but not at this time. The other thing about vaccine that I wanted to bring up is the duration of immunity. And this has become ever more increasing of a concern as folks are starting to wonder about boosters. What does this mean for the Excelsior Pass, as we've talked about before? There's increasing pressure, if you will, at the federal level about potentially coming up with vaccine passports or some proof of vaccination status to be able to do some types of travel or participate in some activities. So there was a study that came out yesterday and actually had CDC a statement in there that there is perhaps more than ever before anticipation that the COVID vaccines likely confer long-term immunity. And that mainly is inclusive of the mRNA vaccines, as they seem to represent the biggest part of the data set. However, all of the vaccines so far, if we look longitudinally, seem to show persistence of protection and decreased rates of transmission. The Israelis have done some of the best data modeling of this so far, and they continue to show that infections amongst vaccinated folks, even now getting close to 9-12 months out from initial vaccination in Israel, continues to show no significant evidence of disease at all. But even in those who are infected, it is still predominantly mild or asymptomatic disease. So there is still a lot of work being done and a lot of discussion about boosters. I suspect as we get closer in the US to that December timeframe, there'll be a much more discussion about boosters coming available. But it does appear that the duration of immunity is fairly enduring at this point. So, for all of us who have been vaccinated to this time, I don't think there's significant concern about waning of immunity unless folks have significant immunosuppression status. So whether that is because they're on medication or they have certain health conditions, this is gaining interest as to whether those folks should undergo some type of testing of their antibody status to see if it is acceptable and or persistent after a period of time. There is no recommendation. So several folks have reached out and said, hey, if I have a patient undergoing chemo, or if I have a patient who is a transplant recipient, or name your reason for immunosuppression, can they or should they get antibody testing at this moment? That answer is no. While antibody testing does exist, as we've talked about before, there's no current guideline as to what would be acceptable or required, and or if their antibody level was below a certain trigger point, there is no qualification for a booster dose of vaccine at this time. So at the moment, I would say there's no intrinsic value of pursuing that because it would not qualify a person for vaccination or for a booster dose vaccination, except in some research trial kind of scenarios. So for the moment, we'll talk more about that. I know several folks have had some interest in that particular topic, but it's not a prime time issue at the moment. The other issue that has come up is dealing with hesitancy and or requests for waivers from providers, and what guidance or provision of evidence is there that we could give from larger agencies or institutions to kind of back that discussion. So this is a difficult one. So, as we talked about before, there were patients who, wanted clearance to say that their viral illness was not COVID so that they could return to work without having to undergo testing. Now we're getting into the, hey, I have reasons, either ethical, religious, personal, that I don't want to be vaccinated, but my job is going to mandate it. Can you write me some type of medical excuse kind of thing? And I think that's becoming more and more uncomfortable as we're dealing with these patients in the office setting. Certainly as institutions of higher learning are going to potentially require that of teenagers before they can come back to college, or teenagers, young adults, I should say. There has been requests of parents who are requesting some type of exclusion or letter from a provider stating that their child is exempt or should be exempt. So I wish I could tell you that there's some uber guideline. There's really not. I totally understand that these conversations are difficult. To some degree, it's just having to provide the best evidence that we can. I do think the couple of pieces of evidence that I would say that could be of use. Number one, this Delta variant discussion. So it's a popular topic in the press right now. So when we get into closed confined areas, especially talking about kids going off to college and that kind of thing, it is probably going to be increasing, especially if they go to certain areas of the country where the Delta variant would be more prolific And there are concerns that that may be more viral syndrome inducing than even the Wuhan and British versions that we were dealing with before. So getting vaccinated to protect against these mutant strands or strains of the virus probably has some value to it. Number two, I think the evidence, every day we're accumulating more and more people. We're now at millions and millions of people who have gotten the vaccine nationwide and worldwide. The likelihood, this is, even though it is under emergency use authorization, it was the most rapid development of a vaccine in history. I think the real world experience at this moment is actually quite good. And every large international agency, even if you have doubts about the intentions of the CDC, if you look internationally, there is no large public health group that is advising against receiving the vaccine, even going so far as to saying that the concerns about potential myocarditis from the vaccine, or what is the effects on women of childbearing age. Almost every organization has come out to say that the potential or experienced risks of the vaccine are far outweighed by the benefits. So, I think the easy answer to your question is no. There is no guideline that I can say we can send to you that you can post in your office that will say, by X legislative body, we are forbidden from providing excuses. But I do think, the increasing desire of the community and fear of what these Delta variants may mean, especially in those who are going to be in small group settings, and the mounting evidence and worldwide support for utilization of the vaccine is probably the best argument that we could make. So I realize that doesn't solve all the world's issues. I wish I could say that we had a better answer. And I know that that doesn't stop the questions from coming. And I'm sure that we'll get more of those questions as we get closer to back to school, or closer to the time when more of these large health providing institutions are requiring vaccination of their employees, that people are going to be looking for medical excuses. But I think, depending on what side of the spectrum you're on, fortunately or unfortunately, the reality is that the prevailing data is that they are safe and effective, and that the only way we're ever going to really emerge from the pandemic is the more people that get vaccinated. So I realize that doesn't really fully answer the question. I wish we had a better answer. Certainly, if some large institution or governing body comes out with some strict rules as to who can be provided medical exclusion, we will certainly pass that along. But I don't know that that's going to come, as there's really no evidence to support widespread exclusion for any major groups. So that's where we stand on that. Now to the question that probably LJ gets more than us, which is, what is this all going to mean for kids going back to school in the fall? Are they going to have to get vaccinated, especially the 12 and older crowd? I know those conversations are ongoing. I know that there will be further development as we get through the summer. Right now, I think most municipalities are trying to avoid that absolute mandate with a 20-foot pole, because they don't want to wade into that discussion. But I do think that there's going to be increasing pressure going forward, especially as other large academic groups and colleges and universities are mandating it. So I can only gather that, probably in the coming weeks, especially once we start transitioning closer to August, and, to our benefit, the Southern schools will be starting sooner than we will in New York State. So I suspect there's going to be increasing pressure and kind of the go before us experience that we saw when, schools in Atlanta and Georgia were opening up and kind of getting to live what their first month looked like before our schools opened up. So I think the long and short is we're going to be hearing more from local groups. The health department, LJ is involved with school systems and trying to determine what those recommendations are going to look like. So I'm anticipating that in the coming weeks, we'll be hearing a lot more about that locally. But I also anticipate we're going to see a growing list of colleges, employers, hospitals, they're going to mandate vaccination for their employees and students. As of right now, because the other folks have been asking, what's the U of R going to do? The U of R has currently not forayed into mandating vaccination for hospital employees. They are going to be mandating, it seems, vaccination for students coming in the fall. So more to come on that, but those discussions are still ongoing, and we'll certainly share that with you going forward. Other than that, the only other piece, and this is more of just a public service announcement, we have seen the volume of pre-procedural testing dropping as a whole. More and more that the U of R specialists are removing the requirements for pre-op or pre-procedure testing, I should say. For operative testing, it's only those undergoing anesthesia-based procedures by and large. But for those who are being sent for pre-op testing, even though the total number is going down, there is an increasing number of people who are showing up without orders, who aren't sure where to go. So remember, the pre-op testing now for the U of R system is being done at the Sawgrass facility, but patients are showing up without orders placed, or with not sure which physician ordered it. So if you are sending patients, please make sure that those orders are either in hand for the patient or in the computer system for that test to be done, because it's taking quite a bit of manpower to chase that down, and patients are getting upset, and procedures are potentially getting delayed or canceled because they're not being able to be done in a timely fashion. So not saying that that's a widespread thing amongst our providers, but just heard that, so I wanted to pass it along to all of you. The final piece is what does the end of the state of emergency mean for us in New York State? The short answer is we are still figuring this out. So things like parity for telehealth coverage, parity for mental health, we've already started to see walking back a bit. Are the payers going to start removing some of the executive order benefits that they were providing? Right now, everyone is kind of in a freeze mode, largely waiting to hear from the Department of Health and the governor's office as to exactly what the transition is going to be. So we all know that the state of emergency expired, and with it, all of the executive orders technically expired with it. However, there has been much discussion that the requirements for health providing institutions largely remain intact as they were. So it has not changed much from the hospital standpoint, and even for most of us. As far as what this will mean for reimbursement for payers and that kind of thing, I think everyone's still kind of in wait at the moment to see what that's going to do. So I will pass it along as soon as we get it. I know the U of R has their legislative liaison team working very closely with the state. I think everyone agrees that the rug kind of got pulled very quickly. Politically, I think the word on the street was that the Republicans were going to demand a special session of Congress to remove the governor's emergency powers around the COVID pandemic if he did not roll back the state of emergency by July. So I think that was part of what the kind of ready, aim, fire, the ready, fire, aim approach was. But nonetheless, we are where we are, but there's still a lot of discussion on what the exact effects are going to be for all of us. So I suspect we'll be hearing more about this probably after the holiday weekend. So as soon as we do get more information about that, we will share it with all of you. Other than that, I don't think I have a lot of new information to share. Renee, did you have anything that you wanted to bring up?
I do not. Thank you for asking, though.
Okay. And LJ is off enjoying fun in the sun, so she is not with us today. So she does not get an opportunity to participate. And I don't see anything in the chat, so we can open it up to questions if folks have them, or if any concerns about anything I just raised. All right, I'm not seeing people popping off of mute or clamoring into the chat room suddenly. So we will call it a day. So 2 weeks from now will be mid-July. Again, we're kind of taking this on a day-by-day basis. So for now, we'll continue as scheduled. But if we decide to start stretching these out a little bit further, I know LJ is anticipating we may have some more information from the schools and whatnot. So we'll plan on keeping the mid-July meeting for now, but we'll be in touch if there's nothing really new to share and stretch it out a little bit further if we need to. So have a lovely 4th of July weekend, and we will see you back in about 2 weeks' time. Take care, everybody. Bye-bye.